puberty today. I really appreciate it. I actually picked this topic because a lot of the referrals I had been seeing over the past few months from our community as a whole. So I identified this as definitely, I think, an educational need. The reason why I'm going to focus more on the delayed puberty presentations is because these are a lot of times the more devastating diagnoses when we come to the reason why I had delayed puberty. And then for a lot of these children, it indicates missed opportunities for potential fertility if they present really late. And so we're going to go over normal puberty and then focus on causes of delayed puberty. And if you have any other additional questions, along the way, please feel free to interrupt me, which I know this group is good for. All right, so what is puberty? Puberty is the hormonal and physical changes our body undergoes to achieve adult height and adult sexual maturity. And these changes are dependent on androgens and estrogens. In females, it depends on androgens to a certain extent, and we'll go over that. And from start to finish, it takes about 5 years in girls and 6 years in boys. And that's kind of a good little pearl for you when you're evaluating kids in your practice that you think might have precocious puberty. It is not normal to move through Tanner 1 to Tanner 5 in 2 years and a year and a half. That is an accelerated rate of puberty, and a lot of times that also has a pathologic cause and would be a big reason to refer as well. So I'd be missed if we didn't go over the Tanner staging, and I find that this tends to be one of the largest areas of discomfort for a lot of pediatricians. You have to get in there and do a testicular exam. There is no doubt about it, because as we're going to talk about discordant puberty, if you're just looking at hair or phallus size, you can be really led astray by what the true Tanner stage is, and you can miss the diagnosis of, for example, Klinefelter syndrome that way. So Tanner 1 is the prepubertal individual. These are under 3 mils in size. There is no pubic hair, and there's a small prepubertal phallus. As our kids are getting heavier, sometimes you have quite a large fat surrounding the phallus that you have to depress to appreciate it. But it's important for you to do that because I have some families that come for a referral of, concern of small phallus, and it's just their kid's obese and the phallus is normal. It's just hidden by a lot of fat. The hallmark of initiating puberty in males is testicular enlargement. Without testicular enlargement, you do not have central puberty. And that's when your testis moves from a 3 ml size to a 4 ml size. You tend to get those kind of long, darkly pigmented, sometimes still fine textured, can be coarse textured pubic hairs, all the way up to having enough pubic hairs you can count them. That's kind of how I was taught to know the difference between a 2 and a 3. Tanner 2 is like, there's like 2 of them. Tanner 3 is there's kind of a little bit more to the point where you can't see the individual hairs anymore. Moving to Tanner 3, you have some increase in size of the scrotum, pigmentation of the scrotum, phallus enlargement, and the testes bump up to a 10 ml testis. And so now there's, adult polypubic hair, can be some axillary hair. This is usually when adrenarche is really kicking into the body odor, the acne, etc. You have continued enlargement in the testis. You usually have more of an adult-sized phallus, and you have an increased distribution in the pubic hair, and that's in Tanner 5. Testes can be generally in the ballpark of 20 mLs and larger. You have a full adult distribution of pubic hair, including onto the inner thighs, adult-sized phallus, and complete elongation, rugation, darkening of the scrotum. Because it kind of overlies all of the stages of puberty for males. So I'm going to use our because we don't have but if you follow along the bottom, we go across as age and years, and this is just for males. You can see that the onset of testicular enlargement, on average, of course, occurs after the age of 9, more commonly in that 10 to 12 range, and at the latest we say 13 to 13 and a half. And so that continues all the way through about 16 years of age. Enlargement occurs usually about a year after testicular enlargement, and again continues through about 15 to 16 years. And pubic hair and axillary hair development begins about 6 months after testicular enlargement and continues all the way through 18 to sometimes the early 20s. And for a lot of men, beard density and body hair density continues to increase through the 20s, And so even if they have a scanty beard in high school, it doesn't mean that's going to be what their mature facial hair pattern is like. That's likely to continue to increase. But a lot of that's genetic too. If the father has a very light beard, odds are the son might have a lighter beard as opposed to the father with a very dense beard. Sometimes, their sons can have much thicker beards younger ages. Something that I really want to talk about though. Your growth velocity changes with your pubertal stage, and guys have a different timing of their pubertal growth spurt compared to girls, which we'll cover in a couple of different slides. Guys have their maximal growth velocity kick in at about 13.5 to 14 years of age, which is later than girls. Girls have their pubertal growth spurt closer to about 11 to 12.5. That causes all those discordant middle school dance couples where the girl's like towering over the little guy because they're fully pubertal pretty much, and the guys are just starting to enter their pubertal growth spurt. And so keeping that in mind, it can help you differentiate. It can differentiate the kids that are constitutional delay from pathologic growth, keeping in mind that growth velocity tracks with Tanner age, and so calculating that and comparing it to your physical exam, you very easily figure out what is normal growth and what is pathologic growth. Okay, so what is normal in boys? And these are averages. Testicular enlargement by about 11.5. If you're not seeing anything by 13.5, 14 at the latest, that would be an appropriate child to refer. Or to begin the lab workup that we're going to go over. Care again starts about 6 months later. Sometimes can be delayed. Sometimes can occur before testicular enlargement happens. The pubertal growth spurt ranges from 12.5 to 15, with usually the period of maximal growth velocity being 13.5 to about 14.5. And cessation of growth anywhere from 16.5 to 17.5. That's when you see that flattening out on the growth curve, which if you had a child with precocious puberty could occur at a younger age. You start to see that growth deceleration. All right, so females. Tanner 1 or prepubertal is no breast mound, no palpable breast bud, no pubic hair. Tanner 2 begins in this stage of breast development. A lot of times it's unilateral to begin with. It looks like a swollen, puffy nipple with a hard marble-like lump underneath it. A lot of times it's normal for that to be tender or painful initially. You don't need to do ultrasounds and all sorts of stuff. It's a breast bud. If it's happening before the age of 8, we still consider that to be how we define precocious and normal in our country. So that should have referral, but that's generally how things begin. And then they get usually a couple of long pubic hairs. The most common area for the pubic hair to begin is kind of that inner surface of the labia majora. And no matter how bountiful it gets, if it is just in that region, it is still considered to be Tanner 2. Tanner 3 pubic hair, when it begins to spread beyond that surface of the labia majora, usually into the muscle region, and then it's pubic hair that is now too many to be able to count or spread in distribution. For breast development, that breast mound now has started to expand beyond the nipple. So they actually have a very small breast mound present. No matter how big that breast mound gets, unless you have separation of contours, which is how we define a Tanner 4 breast, it's still considered a Tanner 3 breast. By separation of contours, I mean if you could kind of like get down and look at breast on the horizon, it almost looks like a sundae with a cherry on top, where the nipple is kind of elevated above the top of the breast mound, and it looks almost like a larger mound with a smaller mound on top. And that's a Tanner 4 breast, and that's the stage of puberty where girls most likely begin to menstruate. And so generally now knowing it takes about, 4 to 5 years to go through all these stages, it helps you better extrapolate for parents when they can expect the first period to occur based on the patient's current stage of puberty when you're examining them. But again, for a lot of this, you have to actually touch the breast to know where the mound is beyond the area. Now kids are heavier too. It's getting much more difficult to discriminate what is glandular breast tissue from fatty tissue. So that you have to touch, and you can't just do it by inspection. Tanner 5 is when the breast contour starts to then smooth into one mound again. So you no longer see that nipple elevation above the breast mound. It's all one smooth mound. And the pubic hair has spread to an adult distribution, which includes full mons region and onto the inner thigh. This slide, the one I showed you for boys, is puberty and growth in girls. So using age along the horizontal axis, you can see that breast budding occurs first, with pubic hair slightly after. However, about a third of girls will develop pubic hair or body odor prior to the onset of breast development. They get their pubertal increase in growth velocity starting here around 11 years of age, reaching the peak of their growth velocity just prior to the onset of menarche, which is around 12 years of age, the average age of the first period in our country being about 12 and a half. Girls are skeletally mature around 14 and a half years of age. So they do continue to grow after the onset of the first period, but the velocity of that growth decreases dramatically. I find her to be nothing sadder than a kid who was a precocious puberty as a girl that was menstruated and then gets referred, because my window of opportunity to do anything to appreciate and enhance their growth is completely done. Their growth curves at that point are quite minimal. They're usually within about 1.5 inches of their full adult height, and at that point, we can't go back in time and crack those growth plates open. And so, you know, my advertisement for precocious puberty, you know, for girls, we try just to, you know, attain a more appropriate genetic adult height. We're also doing it to delay the onset of menarche, which for some girls, just the psychology and hygiene of having a period at 9 years of age is quite difficult. If you have something else like autism, developmental delay, et cetera, that can make that quite challenging. So please Tanner stage your kids, even if it's a sick visit, make sure that you're doing it so that we can pick these children up and appropriately refer in a timely manner. All right, so the average age of TLC, which is breast development in girls, is about 10 and a half.
If with the family history, the parent reports, the mother reports either they themselves got their period at like 9, 10, or like family members, would still a kid to they're starting?
Absolutely. I mean, their parents, for example, if we look at height, right, their mom could have a shock mutation. That's not normal, but it creates some short stature because the parent's short. So just because it happened in the parent, it doesn't mean that it's normal. Okay. And we have the ability to interfere and to change the course of that puberty. For precocious puberty, too, depending on the age of the onset of the breast development, it can be due to something like an ovarian tumor, a brain tumor. So those things need to be ruled out. And then if we say, all right, this is precocious puberty, there's no pathologic cause we can appreciate, this is your option, they always have a choice of if they would like to treat or not. But I think it shouldn't choose whether or not we're ruling out something that could potentially be harmful to the child. And so that's kind of how I approach it with them, is say, you know, these are the various causes of early puberty. These are the things that I think we should look into to make sure your child is healthy and just in puberty early. The benefit, risk, side effects of deciding to treat or not, their choice. And so I think that we need to give them that choice, because just because the mom menstruated at 8 doesn't mean that she likes that she menstruated at 8, and maybe her height potential could have been 5'5", and now she's 5'1". And so I think that, you know, we owe it to the child to investigate it, and then the parent can make the decision on, you know, if they want to treat or not. Puberty is onset of pubic hair growth. Again, it's usually about 6 months after the onset of breast development, but sometimes it happens in the flip-flop opposite. The growth spurt occurring from 10 to 12 and a half prior to the onset of the first period, which is about 12 and a half in our country, and they reach their final adult height at about 14 and a half. So there's two different parallel hormonal processes occurring during puberty. We have what's occurring from the hypothalamus to the pituitary to the gonads, production of estrogens and testosterone. And then we have the adrenal axis, which is the hormones produce the androgens that are responsible for pubic hair development, underarm hair development, acne, body odor in kids. Like I'm saying this repetitively because we get a lot of referrals for premature adrenarche, particularly in girls. A lot of them are going to have that before the onset of true puberty. And I just wanted to kind of touch upon the adrenarche to see what you can do to help reassure parents, because I think there's a certain degree of anxiety, too, in having to come see a specialist for something like pubic hair. And so I think the more you can rule out pathology and help normalize this for families, I think it helps overall. So what is adrenarche? It's pubic hair, acne, and axillary odor, and those things really count as true puberty. Remember, it's testicular enlargement, it's breast development. Parents like, oh, my 6-year-old girl's so bossy all of a sudden. Maybe you have a sassy kid. Sometimes 6-year-olds are opinionated. It doesn't mean that it's due to estrogen. If you don't feel breasts when you examine that kid, please feed into that. They don't have puberty if there's no breast tissue, if there is no estrogen to be causing their mood swings. Sometimes it's okay for girls to be opinionated. And so, go ahead.
What if it axillary odor? I can get that.
So I'll say we'll talk about the workup to do for that, but that is not something that needs to get referred to an endocrinologist. The axillary odor may be due to early adrenarche. There's no treatment for premature adrenarche. It's something that deserves to be watched because we know those children are more likely to enter precocious puberty. So that would be someone that you should probably see back in your office every 6 months, check their growth velocity, make sure there's no breast tissue development. But that's something that is fairly common and is relatively benign. The things for you to check, what I check, are DHEAS, androstenedione, 17-hydroxyprogesterone, testosterone. By that, you will catch congenital adrenal hyperplasia, in which 17-hydroxyprogesterone will be significantly elevated. You'll be able to catch any kind of virilizing adrenal tumor. And you'll be able to define premature adrenarche, where the DHEAS and androstenedione are the two most commonly elevated hormones found in that workup, and they're generally in the Tanner 2 to Tanner 3 range. They're not elevated into the adult range. A lot of them are in the range of the amount of pubic hair you see when you examine the child. The LH, FSH, estradiol, or testosterone are all normal because those are still quiet. Those are hormones involved in central puberty. If you are going to measure any of these things, it needs to get done at 8 o'clock in the morning. Normal ranges are standardized to an 8 a.m. draw, and you need to make sure you're ordering the pediatric assay for it, which is the liquid chromatography mass spec, the LCMS version of the test that you might be ordering through LabCorp request. I can send you the whole presentation if you want.
Okay.
I'll send them to Michelle, and then she can send them out to the listserv. If you get a bone age in these children, they are very commonly slightly advanced. Up to 2 years is what we kind of consider within the range of normal. This is associated with a history of IUGR. Now we're learning that this is associated with the development of polycystic ovarian syndrome in adolescence and adulthood. So knowing that someone had premature adrenarche in their chart, I think is a helpful reminder to you as they start to go through adolescence. So if they develop irregular periods, very significant acne, hair thinning, hirsutism, that's something that you're like, aha, let's work her up for PCOS. So what can you guys do to manage these kids with premature adrenarche? Because if we've done all the workup and you've confirmed that that's what it is and you have no suspicions that anything else is going on, keep them. I need to see them. It's okay. I'm happy to see them, but I think this is something that can very easily stay at your office. So you want to keep an eye on them every 6 months. They have increased pubic hair, usually up to about a Tanner 3. They develop a little bit of acne, axillary hair, definitely axillary odor, to the point where they're like, my 6-year-old's using deodorant. And I'm like, well, that's a cultural norm where we live, but you don't have to if you don't want to. It's safe for their children to use it. We do not expect any growth acceleration with premature adrenarche. We would not expect breast budding to occur or testicular enlargement to happen. And like I said, there is no treatment for this.
You said the bone age can be up to 2 years advanced.
Mm-hmm.
So growth acceleration?
So these kids tend to be on the taller side, but they have consistent velocity that when you calculate it, they're changing at the same rate over time. So I think this is a nice kind of comprehensive slide that puts girls on the left, boys on the right, and just marches you through pubertal progression that we've already discussed. It kind of compares and contrasts how things develop and at what ages they develop. Like I said, I'm happy to share this with you. All right, so how do you define what's late? In girls, generally, we would expect breast development to occur by 13, absolutely by 14. If they kind of stagnated in their puberty, so say you've kind of been watching them go along and you're like, oh, 6 months they're going to get their period. Oh, next year they'll have their period. And then they've been sexually mature for a few years and still haven't gotten their period, that's normal as well. And if they haven't had testicular enlargement by 14, we can that to be meaningfully delayed. And so a lot of the late bloomers is kind of like 12 and a half, 13, or waiting still. A lot of them, if you follow them over time, will have enlargement by 14. But again, that's where the testicular exam is so important. Not all of the past orthodontics are in your office. We appreciate that. Walking to my exam rooms, and sometimes the kids have like gone through my drawers, they have them out and are wearing them as necklaces, and they're like, Dr. Brodsky, what is this? And I'm like, you're listening to that talk right now. But if you kind of familiarize yourself with some common objects that are about the size of the testes at the different developmental stages, it kind of provides you with a rough rule of thumb. Or know on your finger how much is a centimeter versus a centimeter and a half versus 2 centimeters. You know, your first knuckle is whatever, your second knuckle is whatever. So you just have something to be able to approximate. So, you know, the large Cadbury cream egg, the smaller one, and then like, I love the Dove chocolate little eggs to help you get an approximation of what is an early Tanner 2 testis versus a sexually mature testis versus kind of a halfway through testis. Or you can pick yourself up through these.
And we work through those on too.
Yeah, like they're about large Cadbury, small Cadbury. I'd probably get a kick out of that actually, because I read all your notes, so that would be fine. Sometimes late is late, and it's a variation of normal. But now we're going to start to talk about some of the pathologic reasons why people can have delayed puberty. Because sometimes it's hypogonadism. We don't have this set defined age, but if you have a feeling like there's dysmorphic features, or some abnormal growth pattern, or something else that makes you concerned, that should be like your spidey sense going off to trigger a workup or a consult. So other clues can help you figure this out as well. Discordance. When you do your testicular exam and someone has full pubic hair, a pubertal phallus, and then you're like, ooh, those are really small testes. And that would cause referral. Or if you know they have a risk factor, if this is a cancer survivor, if this is someone who had, you know, cranial radiation, severe head trauma, was born extremely premature and has a lot of, you know, brain problems. Those are the people that we should, you know, start to keep on closer sooner. Examples of discordance. And when people have discordant puberty, you might notice I always comment on what their breast Tanner stages, their pubic hair Tanner stages, how much acrylated hair they have, and then sometimes even I'll distinguish what vaginal mucosa looks like. So in a girl, bright red mucosa means no estrogen effect. Pink mucosa means estrogen effect. Then I listed out, sometimes people have a Tanner 3 pubic hair, but a Tanner 1 breast. And I thought it's important over time because it gives you clues that something might not be going on that should be, and it allows you to track it more appropriately. So for example, in a boy who has Tanner 3 pubic hair, but prepubertal 3 ml testes, it's important to take those out as different components of your staging, your Tanner staging. All right, so other things that might suggest hypogonadism, and we're not talking necessarily now about just testicular failure or just pituitary FSH deficiency. This is both of those kind of together in one category. So extreme shortness and poor growth velocity. That is a major red flag to me that this kid can have some degree of hypopituitarism. Not just have LH-FSH deficiency, but have TSH deficiency, could have growth hormone deficiency, and a lot of times those things can travel as one in someone who might just have a small hypoplastic pituitary or an absent stalk or still in the blood. I would kind of persist anuresis as well, because you have a normal, you know, vasopressin excretion. We would expect, you know, bedwetting without any other red flags. You have stopped by, you know, this point in time. Who've undergone bone marrow transplant, head radiation, and I said that one's pretty common sense. Extreme tallness, and extreme tallness that doesn't fit genetically for their family. And sometimes we're so attuned to kids that are abnormally short that socially we might not pay as much attention to kids that are abnormally tall. So I think it's important I measure the parents. I find women tend to lie by about an inch. Dads are like 2 inches off a lot of times. And I record it in the chart. So then that way, as I'm tracking the kid's growth over time, I have a very good idea of what I'm expecting genetically for that child. So it can help you pick up on extremes in the other direction that we might not necessarily pay attention to. Hypoplastic genitalia or undescended testes. Sometimes everything we might think is a testis or an ovary isn't. I just had a case yesterday for an 18-year-old who was referred for primary amenorrhea. She had tanner 5 breasts. No one that her vagina was really a blind vaginal pouch. It turned out to be a 46XY female. She had androgen insensitivity syndrome. So I think that, paying attention to those things and really trying to, quantify when did you notice things started to change? How long has your body looked like what you're noticing now? When you're examining males looking for, hypospadias, a hypoplastic phallus. There actually are established norms for penile lengths for different ages and tanner stages. There's growth curves actually too. If you'd like that information, I'm happy to share it with you. But that's something definitely to pay attention to. And cognitive or social function as well. And as we're going to talk about some of the syndromes that are associated with hypogonadism, I think that will become a little more clear.
How do you blind vaginal pouch? Can you see that on ultrasound or how?
You can't see vaginas on ultrasound. So sometimes, I ask the teenage girls, have you ever tried to insert a tampon? During masturbation, have you ever, put your head there? And I'll look into the introitus. Sometimes if it's very shallow, you can see that. But the way that you visualize it with using imaging is with MRI. And they can see the vagina, cervix, uterus, and gonads that way. And then depending on what's there and what's not, it can help you start to put together what the next steps are of syndromes to look at. Sorry, go ahead. Right, but then the urologist knows that it's a test. But sometimes you can actually have mixed gonadal dysgenesis, and it's an ovogenesis. You can have an empty scrotum and a gonad that got hung up somewhere in the canal or still in pelvis. That isn't true, pure testicular tissue. Not hypogonadism is an extreme kind of pathology. Pubertal flame might not be healthy, and these are mostly things that, especially in the top part, you can easily sort out in your practice. Not enough nutrition. I explain to patients puberty is a luxury. You might want to think about it in your 15-year-old son, but the whole purpose of it is to reproduce. And your body doesn't deem itself healthy to be able to do so. It turns your puberty off. And so kids that have severe eating disorders, who have horrible stimulant-induced anorexia, who have inflammatory bowel disease or celiac disease and can't absorb their nutrients properly, they're going to have pubertal too. And so those are points to hit when you're doing your, your history information. I do a full dietary intake in a lot of these kids because I want to get an idea of what is their energy balance of intake and expenditure. I had this one boy who had a health class at school, learned about obesity, scared the heck out of him, so he started restricting his intake, and he was doing P90X every single day. And net taking in about 300 calories a day, and his family wondered if he wasn't going through puberty. And so I feel like a lot of these things you can easily find out just by asking the kids some questions. Chronic illness or diabetes causes malnutrition because their calories are going out in their urine because they're not taking their insulin. Chronic renal disease, cystic fibrosis, chronic inflammatory disease. All things cause kind of a net balance of energy expenditure versus intake. And hormonal problems, severe hypothyroidism, growth hormone deficiency, Cushing syndrome is a very, very, very rare thing, or PCOS. The high testosterone levels can impair with the onset of menarche. So those can be the obese girls, acne, hirsutism, who are still immature and never had a first period. Depending on their kind of overall status. If they're a healthy, robust kid with sickle cell, like nutritionally, then generally they have normal puberty. If they're not, then that can cause some delays. So a lot of it has to do with chronic control. So getting into the questions that I tend to ask myself when I'm evaluating these patients, what is their growth pattern like? Is their height appropriate for their family? What is their growth velocity? And that's why I play bureaucracies and I request for the growth curve, because I do calculate that when I see them, and then I look at that according to their Tanner stage, and it helps me figure out is their growth normal or pathologic. Their nutritional state, how do they see themselves from a body image standpoint, and what is their dietary intake? And of course, look at their level of physical activity training that they do, because that can be excessive as well. In their past medical history, you want to come up with diseases and treatments that can possibly cause pituitary damage or gonadal damage itself. symptoms, you want to ask about frequency of bowel movements, care of bowel movements, are they having repeated respiratory infections, and then behavioral symptoms as well to help think about some of the associated syndromes. Physical exam, I'm looking for dysmorphic features, signs of chronic systemic illness. I look at their fat stores. And then I start to do an inventory of their androgen features and their estrogen features for girls to be able to start thinking to myself, all right, I have some pubic hair but no breasts, or I have pubertal phallus and pubic hair but no enlarged testes. Is concordant or discordant. Again, so all these things you guys can easily do. I encourage you to do. I like it when you do it. Just make sure that you're using the correct testing to do it. Bone age. If you ever have a question about a read on a bone age where it came back like very different than what you expected, I'm happy to look at it for you. I found in our community there's a lot of variability in how skilled radiologists are at reading these things. That's why I ask the patients to bring them on a disc to their appointment. Base screening, looking for signs of anemia, looking for kind of renal, electrolyte abnormalities, liver disease, UA, signs of inflammation, easy thyroid screening. You can do an LH and FSH if you're concerned for precocious puberty, but again, 8 a.m. with the pediatric assay is very important. And then depending on what you see on exam or you get from history, you would pick other specialized tests appropriately. If the chloride is off and the kid has chronic respiratory infections, you might go the route of the sweat test. If it's someone who you're concerned about, crampy abdominal pain and, poor weight gain, celiac screen. I think all short girls or girls with markedly delayed puberty absolutely deserve a karyotype. If the karyotype comes back negative and you have a very strong suspicion, order a microarray. For a karyotype, most of the time they look at 20 cells, and for a Turner mosaic, sometimes that can be missed if there's a very low level of mosaicism. And so I do that more as a second step test. If I'm looking at the chart, the kid and the growth curve, and I'm like, this has to be a Turner, then I'll order a microarray as a secondary test.
Other EAIS and 17.
So that's if you are looking more for the adrenarche. This is more like there's breast and no testicular enlargement, and it should be there. Generally, things like CAH, for example, which is the main thing we want to rule out in realizing tumors. For realizing tumors, they have very rapid variation. So girls will have tremendous clitoromegaly. They go from having just a couple of pubic hairs to full adult distribution in a few months. Remember we talked about premature adrenarche. Usually they only get to about 10 or 3 in those things. The virilizing tumors, they progress more rapidly. In boys, a big sign of it is very rapid phallic enlargement without any testicular enlargement, and a boy that is too young to be having that degree of sexual maturity. Kind of more the adrenarche workup. This is more like the puberty is missing, where is it workup. And based on that evidence, I tend to think about kids in these 4 risk baskets and help me figure out what steps to take next. So there's probable constitutional delay, probable pathologic delay due to some systemic disease or malnutrition, which has nothing to do with endocrine. Probable gonadotropic deficiency, so they don't make enough signal from the brain to the gonads. Or actually probable primary hypogonadism, which means the ovaries or the testes for some reason aren't responding to the signaling from the brain appropriately, gonadal failure. So characteristics of constitutional delay. They have no red flags in their history, past medical history, review of systems, screening lab, exam. They have normal nutritional status, and their growth velocity is appropriate for their Tanner stage. They just seem like kind of healthy, younger, smaller children than you'd expect for someone of their age. A lot of times the family history is positive, just like how Kimberly said, sometimes for precocious puberty there's a significant family history. These might be the kids where the mom menstruated at 14, the dad says, oh, I didn't have my growth spurt till I was almost in college. So asking about those familial pubertal tendencies is very important and can give you very important clues. All aspects of their physical maturation are concordant. So their pubic hair matches their phallus, matches their testes, the breasts match the pubic hair, the axillary hair, etc. And very commonly they have bone age delay. This work, though, can't help you differentiate between these kids and the kids that have gonadotropin deficiency, so not enough LH-FSH, right? These are prepubertal healthy kids. So if you did 8 a.m. lab work, LH-FSH prepubertal. Tropin deficiency, LH-FSH will for the rest of their lives remain pubertal. And so these other characteristics are kind of falling into suit. The big one is growth velocity is normal for Tanner stage. This is a growth curve of a pretty typical constitutional delay kid. So there's a boy. You can see up there where TG is, that kind of gives you the mid-parental, which is an estimation. It's not a clear-cut, dry target height for a child. They're growing at a normal velocity, but you see where everyone else starts their pubertal growth spurt, they still grow at a slower rate that's more characteristic of the prepubertal part of the growth curve. The appropriate pubertal growth spurt just shifted to the right compared to their peers. And in a lot of growth curves that aren't computerized, the tearaway ones, on the back there's actually growth velocity growth curves. So you can take their growth velocity, which is what this curve is here in the box, and you can plot it, and they tend to have normals for precocious puberty, average puberty, and delayed puberty. If your opposites like some of those, I'm happy to give them to you. And that kind of helps you be able to follow the growth velocity for age and be like, oh yeah, they're on that delayed curve, things are speeding up, testes are enlarging, everything's looking good. Go ahead.
Do you find just as kids who have decreased fat mass, or body mass, those have obesity have an earlier onset of puberty, or is that not something you can extrapolate?
The study that you're probably alluding to was the one that came out a while ago that was done all by general pediatricians on inspection of children to say, oh, the age of true puberty is shifting earlier. It was published, I believe, in the Lancet. And it didn't involve endocrine analysis, part of the study. It didn't involve palpation of the breast bound to be able to differentiate adipose from tissue, and it didn't involve any laboratory testing to be able to measure when the patients had a rise in gonadotropin. And so I think there's emerging evidence, particularly in certain ethnicities, that the onset of breast development is earlier. We still use this as our current rule of thumb. I can tell you insurance providers definitely still use this as who they'll cover for, for precocious puberty, particularly therapy for. And so I would say if you have someone you're worried about, you can definitely send them. But we haven't truly changed how we define it yet in our country.
So obesity doesn't.
So probable pathologic delay. These are the people that, you're doing your intake and, all day the kid is eating, 20 goldfish after school because that's the only time they're hungry, or they have other signs of chronic illness, or some other endocrine disorders picked up in your initial evaluation, like you're doing your exam and you find a goiter. And the patients, their ICE and FSH are not elevated, so again, they're prepubertal or very early pubertal, and their bone age also can be delayed. Most of the clues you'll get are from the other labs you did and from the history that you took. So clues in these kids. These are kids that if you have a concern for GI-related stuff, don't waste time sending them to me because I'm just going to send them to GI anyway, and then we've lost like a month of time. So pick the specialist that you think the underlying cause is most likely related to and refer to that person immediately. Gonadotropin deficiency. This is the inability to make LH and FSH appropriately, but you have normal intact gonads that can respond when signaled. A lot of these kids might have other pituitary deficiencies. So when you do your thyroid screen, you'll notice like the TSH might be low normal and the free T4 is like abysmally low. So that's inappropriately normal TSH for that degree of low free T4. You do your growth factors, they're in the toilet. Those are the other clues you can get to these children. Growth is usually worse than their pubertal delay pattern. So when you look at growth velocity, it's low for their Tanner stage. You want to look for other, stigmata that can help you figure it out in the history, cranial radiation, head trauma, et cetera. And you want to ask about sense of smell. That's a very big component of disorder called Kallmann syndrome, which is hypogonadotropic hypogonadism, is due to a variety of mutations, and they have underdeveloped or lack of development of the olfactory bulb is a part of that disease. So the mom will be like, yeah, he never knows when dinner's ready. He can never smell it downstairs. Or the whole family can smell a skunk outside. And the kid's like, what? So, you tend to ask certain things like that. There are standardized ways to test it. There's actually a clinical trial going on now at Mass General that kids whose insurance won't pay for genetic testing, like a recent patient of mine, you get all the full genetic testing through them for free. So that's, other things to look for. Other features that might make you think of a hypothalamic syndrome, and the big one is, Prader-Willi These kids, a lot of times their bone age is not, you know, in the pubertal range. It's pubertal, but you're like, well, where's the puberty? You open their mouth and you see the 12-year-old molars, and there's still like a 10 or 1 or 2 on exam for a girl, which doesn't match. These kids might have, you know, hypoplastic genitalia, so they have a very, very tight scrotum, undescended testes, still have inguinal testes, and their LH to FSH tend to be low, again, inappropriately low normal, given the degree of sexual maturity you would expect. And a lot of times these are the kids who have those discrepancies or discordant puberty on exam with pubic hair, underarm hair, body odor, but no testicular development or breast development. Primary hypogonadism, these are the kids who have gonad failure. And so some you can pick up on a specific diagnosis, like they might have features of Turner syndrome, where they have streaked gonads or, you know, ovarian failure. Again, there's a lot of discordance on exam, and the LH and FSH are like through the roof elevated. Even if used in adult assay, they're in the like postmenopausal range for women. For men, they're elevated, and by that I mean like 30, 40, 50 higher. Their bone age may or may not be delayed. For this, it's the lab testing that really helps you figure that one out. And this is something I absolutely, boy or girl, do a karyotype for. With you a patient that was referred to me. He was referred at 18 years of age because he himself had noticed small testicular volume that he pointed out to his doctor at his physical, and also was very troubled by some gynecomastia that had started to develop. He says he first noticed it about 2 years ago. He had onset of pubic and axillary hair development, though, at 13 years of age, so about 5 years before his presentation. A lot of times I'm like, well, when did you notice your testicles started to enlarge? And the boys are like, I don't know. And so I'm always like, well, that's okay, I'll check. But a lot of times they can't recall when that might have started. I always ask about erections. You would expect an 18-year-old guy to have a lot of morning erections, spontaneous erections, which he says he rarely has. And even during masturbation, he can obtain an erection, but he can't actually maintain it long enough. Past medical, surgical, family history were unremarkable. In guys with gynecomastia, I always ask about dietary supplements, marijuana use, supplemental testosterone use, or other substances, because those can cause gynecomastia, low libido, small testicular atrophy in this population, so I ask them those questions as well. 74 inches, which is the 95th percentile. His weight was at the 88th, and his BMI was at the 70th. Bilateral Tanner 2 gynecomastia. And we did his testicular exam. His left testis was 5, his right was 8, so he's Tanner 2 testis. Tannic pubic hair, moderate axillary hair, a full pubertal phallus, and very, very scant facial hair. So is his exam normal for an 18-year-old? Your differential diagnosis in small testes, but mature penis and pubic hair. That's one of them. So that probably would have presented with more accelerated growth, short stature, untreated, unclassical CAH, or even classical, which would probably be dead by now, to be honest, with just premature stunting of growth. So anything that can affect the testicles, right? Or to a certain extent, the signaling from the brain to the testes. You know that he's likely hypogonad, you just don't know if it's primary or secondary yet. So what would you do next for him? So what? Definitely karyotype, FSH, LH, testosterone. So I can tell you for him, his FSH and LH were very, very, very elevated. 8 a.m. testosterone would be like 400 to 800. His was 150. And his type was XY. So my patient ended up having Klinefelter syndrome, which is hypergonadotropic, so elevated signal from the brain to the testes, hypogonadism, testicular failure, common. It's more common than congenital hypothyroidism, and we screen that on our newborn screen. The hypogonadism might be partial or subtle, so they might initiate puberty and then have gonadal failure, They have tall stature, a lot of times uncharacteristically for their family, and that starts even in childhood. They develop pubic hair, but their testes are small, and that's why the testicular exam is crucial. A lot of times by the late teens, they develop the characteristic body habitus, which my patient had. They're really muscled. They'll tell you, I try to work out and I just can't bulk up, long limbs and the gynecomastia. Some developmental delays, but some of them are completely fine. I have one of mine is a student at MIC, actually. They do have a small risk of tumor and breast cancer, so it is important to educate them on that, and I do breast exams when I see them in the office. The saddest thing about these patients is if they're just early enough, you can collect sperm from them before their testes fail. And they're not referred until they're 18 years of age and they already have gonadal failure. They're shot for fertility, done. That's why testicular exams are important. By not doing them, these patients are robbed of fertility. And testosterone. Testosterone is important for cardiovascular health. It's important for bone health. We only build bone density till about our mid-20s. The boys who are hypogonadal are not accruing it as they should be, and they're going to have a smaller period of time for catch-up bone density. And sexual characteristics. So psychologically, a lot of times, they feel very abnormal. They don't have facial hair. They're very thin usually. The gynecomastia is very bothersome to them. So, these are boys that I always feel horrible when they, some of them are like, I always knew something was wrong with me, and nobody figured it out, or nobody looked, or I'm the first person giving them a testicular exam. So please do them.
What, if you did happen to catch them and like what are happening to them?
It's not inherited like an autosomal dominant or recessive way. So their sperm, right, exactly. So they can have genetically normal children.
Were them for the sperm collected at endocrine or urology, or where
So you'd probably start with me because I would do lab work to see if something's even viable anymore, and then I do a semen analysis. If there is something available, I have a person I refer them to who is more sensitive to working with boys of this nature. Sometimes also they can do testicular tissue harvest, so they can use some hormonal stimulation of the testes to drive sperm formation, and then actually save the section of the testis that has the sperm in it, depending on how young they are. The other thing that can result in gonadal failure that is relatively common is Turner syndrome. So that is on the right an example of a karyotype of a woman with Turner syndrome. She is XO. There are multiple variations of Turner syndrome where you can have one full X and all parts of midgens to nothing of the second X. These kids have growth failure that begins in infancy, actually, and then becomes very, very pronounced through childhood and absolutely during adolescence. This is something, actually, that growth hormone is approved to be used to help augment growth in. And some of them can have, I have a couple Turner girls in my practice that are bigger than me. And so a lot of things in early childhood, if they don't have tons of dysmorphisms, is a lot of recurrent ear infections. In the AAP guidelines for the health maintenance of girls with Turner syndrome, there are scheduled time points where they need to have hearing evaluations because they're at great risk for hearing loss because of the recurrent ear infections. Not always, but a lot of them can have some subtle dysmorphisms as well. So in infancy, you can notice there's a lot of times some puffiness of the hands and feet, the lymphedema, the redundant skin folds in the neck, the low posterior hairline, the low set ears. They tend to also, what noticeable are the wide-spaced nipples. Some of the other parts of the phenotype might not be as apparent at birth, but as the kids grow up, you can definitely notice in the middle the webbing of the neck with the low hairline, the wide neck to the right, and on the left, the low set ears, I think, are really noticeable as well. They also tend to have a very high arched palate with dental crowding, an increased carrying angle of the arms. So this angle tends to be widened. They can have left-sided heart defects like a core. All of those kids, girls with coworks, need karyotypes. And they have spontaneous onset of puberty. Some of them can menstruate. The mosaics can have prolonged menstruation and develop normal breast tissue. An example of a famous person in Hollywood with Turner syndrome. I don't know if any of you watch NCIS, but she's this character that's really, really small. My husband was watching me make this last night, and he loves that show. He's like, that's why she's so little and looks like that. And I'm like, yep, exactly. So a lot of girls with Turner syndrome do have intellectual deficits, but not all of them do. I have some Turner mosaics in my practice that are going to regular college courses. And syndrome can be very variable. So delayed puberty in a girl, stereotype, short stature in a girl, stereotype. It's such an easy thing to rule out, and given that it's about 1 in 4,000, which is the incidence of congenital hypothyroidism, they're out there, and we're probably missing some of them. So we use the appropriate growth curve when we follow these patients in our practice. If I see one of your Turner kids, I'll usually photocopy my Turner curve and give it to the parent to give to you. It is available on the AAP website. If you go to the article, the guidelines for health maintenance of girls with Turner syndrome, it's present there as part of that article. It also has a great table for you as primary care physicians at what age points you're supposed to be referring them for different evaluations, doing different lab screening. Whenever there's a new onset Turner, there's a lot of other things you have to look into. They can have kidney malformations. They need a renal ultrasound. They can have a coarct. They need to go see a cardiologist and have an echo. And then as they get older, we very closely watch their puberty and growth as well. So it covers most of what I wanted to cover today on the basics of puberty and then particularly pubertal delay. What questions do you have for me?
What is normal? What normal for gynecomastia a child to avoid?
So gynecomastia happens in about 50% of guys. It's more prevalent in Tanner 3 to Tanner 4 development. It can occur in Tanner 2. It usually doesn't progress much on a Tanner 3 breast mound, and a lot of times there's a positive family history for the father or an uncle or someone else having it. About 95% of that breast tissue will regress as they progress through the rest of puberty, so keeping a close eye on it is important. There is, if you're very worried or it's rapidly progressing, different workup you can do to look into like a feminizing tumor in guys. A lot of those are testicular tumors, so again, your testicular exam comes in handy. But if there's someone that you're worried about rapidly enlarging gynecomastia, that would definitely be an appropriate referral. Stable, minor, especially bilateral gynecomastia is something that, like I said, is relatively expected. If it's prepubertal in nature, it's more likely to be pathologic, but if they're Tanner 3, Tanner 4, that's relatively common.
Do germinal tumors that present late tend to have any effect on puberty?
It can cause problems with virilization, and so depending on what the combination of pubic hair versus versus testicular volume is, then those are the ones where I might order hormonal markers to see if there's any other type of tumor that could be presenting. So like P and beta HCG are the big ones to do so. That's an endocrine marker. So can we talk about all day?
All the schools want a Tanner stage. Which we give.
So most kids will be concordant, so you can only have to list one. I would say that I use for school purposes. I mean, if you're really cerebral about it, you can split them out for them. But I would go with breasts and testes as being the dominant ones because that is the mark of true puberty in children. That's what they're worried for. They don't want some little pipsqueak of a 14-year-old who's making no testosterone out there with like this raging bearded, huge muscled, 10 or 5 senior. So.
Growth curve to parents. When can you project their?
So I always preface my statement about that with, this is an estimation. Using parental height, our wiggle room for error is 2 inches on either side of calculated average, which I think is a pretty easy estimation. And so that's how I started. If I'm doing a bone age, I tell them I can get a little more accurate using your bone age, but that's still an estimation with a wiggle room of about 1 inch on either side. Generally, we start to rechannel into our more mature growth patterns in early childhood years, so probably around 5 or 6 or so with consistent growth, barring any issues with poor weight gain. That's usually a time where you can start to provide that extrapolation, but I wouldn't hang my hat on it too much because it is just that, an estimation.
About that, take height at 2 times a 2 estimate.
That's even worse than using the parental height. So I don't go there at all. So yeah, no. I'm going to provide a mid-parental height estimation. I'm for sure going to measure those parents. Like the lug old construction boots that come in, that's like my giveaway. Like an overestimator of height. So if I'm going to go through the purpose of providing an estimation, I have the parents pop their shoes off. Usually the kids get a kick out of the fact that the parents get measured. And I measure the parents too.
This would be more accurate for the estimation, the mid-parental height, or following, like, say, 50th, or following 50th percentile on the growth curve and extrapolate?
I'd probably use both, to be honest, because the mid-parental helps you get an idea of how appropriate their current growth is. So 50th percentile might be way below where it should be if the dad's 6'4" and the mom's 5'10". That should be someone who has abnormally poor growth for their genetics. And so I would say I don't use one without the other. Any other questions?
Adrenergy is not as important, but is there like an age that, like 4 with a 10 or 2 or?
No, you have to keep an eye on it. Right. So anarchy, like I said, it tends to not rapidly progress. It doesn't cause growth acceleration. It shouldn't cause penile enlargement. It can trigger true early puberty, so you should be keeping an eye on the testicular exam. But when I get those kids in the office, I'll do my initial workup and be like, all right, we're not dealing with CAH, and I just have them either see you or me every 6 months until the age at which normal pubertal onset would be considered normal, and then I turn them loose.
Do you do imaging, initial workup?
Like
imaging, like if you're worried about ovarian tumors and
for what? If I'm seeing just adrenarche?
yeah.
If there are no red flags on exam or on their growth curves or on laboratory testing, I usually will not do that as a first step. If I have concern, usually I'll do the imaging if there's signs of true early puberty. And so then I'll move to doing, like, for a girl, a pelvic ultrasound. I want to see, is the uterine volume appropriate for a prepubertal or a postpubertal kid? Are there any ovarian tumors, any of that stuff? But generally, any badness is going to cause really rapidly progressive virilization or puberty in general. So that's why follow-up is important.
Even a renal tumor?
Renal tumor, it'll be very rapid, and usually if they're presenting with adrenarche, the little girls will definitely have clitoral megaly. They'll have full pubic hair. Sometimes it's even triggered some breast development. So not like a couple of pubic hairs or like a whiff of either is not going to be an adrenal tumor. However, if it goes from that to pubertal vellus and, full pubic hair in 6 months, yeah. So I educate the parents. They say, this is why you need to go get the blood work done I'm asking you to do. This is what I'm looking for. This is what I would expect to happen over the next 6 months. If these other things occur, that can see me right away, but otherwise we'll space again in 6 months per time. So, education is important. I have handouts I can share with you that goes over, like, what is adrenarche, what to expect, what is post-puberty, et cetera. Go ahead, Ann.
Just because, sometimes it's really hard for us to do genital exams on patients. But I find that if you start doing it from the time they're little, it's so much easier than taking a 13-year-old who's never had this exam and say, okay, now I'm going to check you, and they're really feeling violated. So, I think it's really much better. And if you're worried about doing it as a male with a female patient, as a female with a male patient, anybody over 12, I always have my nurse with me. I say, this takes two, no big deal. And it just protects you. And then if you ever question, you can say, everybody over 12, I have my nurse with me, male or female.
I think the more you can normalize it as, when you come here and I listen to your heart, I listen to your lungs, I do a pubertal exam, I think that that's appropriate. With every ear infection, do you need to be looking at the kid's pants? Probably not. But for kids that have inconsistent follow-up and might not come for a well child visit for a few years, I would use that as an opportunity do height. A lot of places don't do height-specific visits. That's a great opportunity for you to check in on the overall health of the child. And I agree with you. I work it in. I also keep patients in gowns when I see them. You'll be amazed at the number of cutters found that people had no idea was happening. So you have to look at older skin. It's important.
So how about the extreme athletes that delayed puberty, the gymnast or the...
That's abnormal. They're an extreme athlete to the point that nutrition has been sacrificed and normal puberty. And so that's what I tell, adolescent gymnasts that I meet. For me, a healthy body weight for you is one where you get a period every single month. And just because half your team doesn't get their period, it doesn't mean that that's right or okay. And so I try to explain that to them.
So, when should we say, I'm not going to the Olympics?
I say that to parents. It all depends. If it's I think you have to first look to make sure that that's truly why they have no puberty, right? You might, I thought that girl who was the 46XY, I would have bet $5 she was going to have PCOS. And so I think you have to do your due diligence to make sure that what you think is the most likely cause is the most likely cause. And a lot of times your growth pattern will help you out. But if you have a Tanner 1 14-year-old who spends 4 hours a day doing gymnastics 7 days a week, and you do her dietary intake, and you say, look to the parent, your kid consumes this amount of calories per day, she's expending this amount of energy per day. A lot of times until you go through that with them, they're just like, oh, wow. I think that things start to change at home. I would also take the step of referring them to a nutritionist. But I think once you've been able to rule out everything else and it does come down to that, then I think you do have to have a talk with them. Maybe she is going to the Olympics, but at the same time, she's going to develop stress fractures for nutrition. So I start to try to use some of those other things that can impact what she cares about which is the gymnastics, to help get some buy-in to make family change.
Do you see it at all, or in
I've definitely seen it in boys. A lot of them are cross-country runners. Some of them are starting to do these more extreme home exercise programs, like that kid that did P90X. That's really intense exercise for almost an hour, very intense exercise for almost an hour a day. And so, asking them, not just, I play soccer, but it's 3 days a week. How many hours a day? What are your workouts like? I'm less concerned with someone playing softball 2 hours a day where they're versus someone who, is a cross-country runner and runs 5-10 miles per session. No, I agree with you. Mm-hmm. Yep. Yep, I agree.
Okay.
Do you need a break, or can we just move right straight through? Do you have, Kathleen McGinnis? Kathleen is going to be first guest today, perinatal safety nurse, talking about the